Welcome. I'm David Markel. I'm the market president for the Core Institute here in Michigan. Just a few housekeeping details. This is a little bit of a departure from our norm. As some of you may know, our norm would be a virtual lecture, or used to do live lectures pre-COVID, where we would have a presentation on a particular topic and then engage questions. What happened, I don't know, 4 or 6 weeks ago, we did a talk, and it was a very gratifying and very strong response rate. We had, I don't know, over 100 people on the video, and then the number of questions kept coming in, and I felt bad that we were going to have to cut off the questions. So I suggested to Sarah that perhaps we would just do a session only with Q&A. So while I'm happy to answer any or all questions to the best of my ability, we are a little limited by having either video or other schematic materials to show you. So, if there's a question about a hip implant, typically I'd be able to show you a hip implant or would have taken that from a question. We're going to try to have, excuse me, some of slides available, but I'm not really confident we're going to be able to flip back and forth without having some technical issues. And for those of you who were on before, I do apologize that we had a internet problem. So I think the last time we were together, things were quite jumpy and things cut off a bit. So with that, we'll start with questions. Just a couple other things. Firstly, I hope everyone has gotten vaccinated. Things are widely available right now. I want to at least give you confidence. The vaccines are safe, they are effective, and necessary. So, often we don't really appreciate things until they touch us. I'll tell you, I had a patient in today who we scheduled for a knee. She had COVID in January, as did the rest of her family. Her husband passed away, and there's no question that this affects people very strongly. So encourage your friends and family to get vaccinated, and let's try to bring us up to herd immunity and try to move past so we can all be together the next time we talk. Anyhow, I think the format here is going to be, you guys are submitting questions. Sarah is going to read the question as best she can. I will try to interpret the question as best I can and try to give an answer. Core is a strongly managed program. So for the vast majority of routine primary implants, we all basically use the same thing. There are always reasons that things may vary. So there may be unique circumstances for a patient which would make them better to have a different product. That being said, we've all used lots of different products. Generally, you fall into the path of what you're using. We like, as a standard practice, to be using very similar things. That way, from standard of care processes for quality, if we're all using something and doing something similarly, if we find a complication, we're then able to track how and why that may have occurred for process improvement. But I guess the short answer is yes. So if you have equal severity hip and knee arthritis, generally we would want to fix the more proximal or the joint above first, because it is very common that the hip will cause referred knee pain. And if you fix the knee first and you have trouble getting your knee straight, or if you have continued knee pain, then the question always comes up, is some of the pain coming from the hip, or is the problem getting the knee straight because your hip can't get straight and reflects down below? So that is a much more sophisticated question than you appreciate. So the first thing is, most all of the implants we put in have very, very low nickel content. Now, in the hip, since we can put in a cup and a stem that are both titanium and a ball that would be ceramic and a plastic, we can effectively eliminate nickel from the hip. In the knee, we don't really have that option for the most part because the titanium is too soft of a metal to have as the bearing surface on the femoral bone or the top bone. Now, if there was an actual concern of metal allergy, which it sounds like there are a couple implants that have resolved that. So I'm not sure if I could get into brands, but for example, Smith & Nephew, one of the large national companies, has a implant that they term oxinium, which is what they do is there's a process basically where you take the prosthesis and they treat it. And so the end of the metal is effectively a ceramic. So that basically takes any nickel component out of the bearing surface, so you don't have to get that worry about that getting into the joint. Zimmer and Esculap both have similarly treated products. Those are less established in their long-term outcomes. But if there was a concern, we definitely have ways to address that. If one was really concerned, then there's some testing methods that are blood tests that you could define exactly what the allergy is if present. But again, if there's a concern, we have a couple different implants that we can flip to that are very good implants that eliminate all nickel entirely. So I think I would answer the question a little, or I would ask the question a little differently. So PRP is not in any way an alternative to a knee replacement. When you're having a knee replacement, you have reached the point of pain, deformity, x-ray changes, and exam that you are effectively past the point where the conservative treatments are going to be effective. In less severe cases of arthritis, let's just say very early arthritis, things like PRP and other stem cell products can be effective at helping pain. They will not fix your arthritis. They will not grow back cartilage. They are not disease-modifying drugs. So if you said, I have some joint space left, I'm very functional, I used to use cortisone, I tried hyaluronic acid, and I would like to try something instead of moving forward, you could try PRP. When you're doing PRP for knee arthritis, it's typically a 3-shot course. And the goal is to help with pain. I don't know that we have any standards on how often you could repeat that. But that being said, one has to remember all of those products are effectively off-label and they are all cash-based. And I think that in general, you have to be a little careful as to how and who are recommending stem cell treatments and why they're offering it, particularly when you're paying cash. But just be wary. There's no magic there. And, you know, it's one thing if you say, I'm trying to buy some time, another, I'm trying to avoid an operation. I mean, if you're headed toward a knee, you're headed toward a knee. The PRP or other stem cells aren't going to prevent it. I hate doing bilateral knees. Never liked it. Used to do it. Usually it was fine. Sometimes it wasn't. My problem is that when you do both at once, if you have a problem with one side, it definitely affects the other side. Secondly, it can be a pretty big hit. Right now, for partial or total, you know, I do your knee, you can get up, you walk, you go home, you go to therapy the next day, and you're gaining your independence quickly. If everything goes well, we'll do the other side at 6 weeks. Within the 3-month cycle, you have both done, but at least you always had a good leg to stand on. And we knew that the first side was going well before we did the second side. I don't think that changes whether you're doing partial or total. The data on medical complications is definitely higher with bilaterals, as one would expect. It's a bigger operation. And I don't know that there's much downside to getting the worst side done first. Just another anecdote. It's very common that you'll have both knees bad, you do one, and the other side feels better for quite a long time because it has a good leg to help it. Alternatively, it may not keep up, and that way, that's also a good problem because it means the one you did is doing well. So for me, I don't like them. That doesn't mean you couldn't have bilaterals and have it come out great. Hip resurfacing is hip replacement. So I'm not going to share right now. When you do a total hip, we put in a stem with a ball. There might be one sitting on my desk. And then we put in a cup. And so you have a new ball and cup. When you do hip resurfacing, you do put in a cup. It's a 1-piece cup instead of a 2-piece cup. And it's on the femur side. Instead of removing the bad bone and putting in a stem with a new ball, you take a female reamer and you go around the ball and change the shape of the ball and take off the bad part. And then you cap the ball that has a little stem. So you still have a metal replacement on one side and a metal replacement on the other side against the bone. In a total hip, we would then have a bearing in between. In the resurfacing, it's a metal on metal device. I do resurfacings. I liked resurfacing, but the problem with resurfacing was that it was a metal device, and metal bearings fell on hard times because they had early failures and they had metal debris and ions that caused failures. What we learned was if you narrow the indications of resurfacing basically to men who are fit with good bone, 50 years old, 48 to 55, in that range, that the implants seem to do well and work fine and seem to last. When you go outside of those realms, particularly in women or small boned people or people with osteoporosis, they are a disaster. So what we've learned over the last 10 years is we have to be much more narrow in the indications. For the right indications, it's fine. And avoid things that are outside of that. Now, that being said, the most important, so again, it's a total hip. The most important part for all of this is, good prep, good management of comorbidities, good technique, and those usually lead to a good outcome. So short answer, yes. And I think we got an explanation for what it is. No, all the major companies really make very good devices. The first, as I've told many people, looking at the big 5 implant companies, it would be similar to saying, I like Mercedes, I like Audi, I like Cadillac, I like Mercedes-Benz. All of them are super high-end cars. They all have great track records. They all do fabulous. But any knee has to be put in straight. It has to be done with good alignment. It has to be done with good technique. And if the knee goes in well, it has no complications, you should be able to do most anything you want. The one hedge I would give is you're not going back in time. So think about how you are now, what you can and can't do now. When you have your knee done, more than likely you will be able to do what you do now better and with less pain. You are not going to go back to what you did 10 years ago. That's just not going to happen. So you have to think in the present and the now and make that better, not try to go home again. So if you were on before when we talked about PRP, I would link PRP into stem cell treatments. There are basically 3 different kinds of stem cell treatments per se. One is taking some belly fat. So those are liposomal mesenchymal stem cells, liposomal being fat. Bone marrow stem cells, which you have to aspirate bone marrow, or PRP, where you draw blood, spin it out, and take a platelet-rich protein, which is a sort of a form of stem cell as well. I would say there's reasonably good evidence that PRP and some of these others are effective for inflammatory conditions like tendinitis. The evidence for very early arthritis and pain are not too bad. I would be cautious again on who is selling what they're charging, and what they're telling you is going to happen. But any of these treatments may be effective to help your pain. They are not going to grow cartilage back. I can assure you of that. And, when you're seeing these ads with x-rays, oftentimes they don't really show you that one x-ray was weight bearing and one x-ray wasn't. But you have to be careful of who's selling what. But again, if the goal is for pain relief to buy some time, or if you're a very young, a 38-year-old, 40-year-old person with some early arthritis trying to, get a salvage and buy time, not unreasonable, but it is not going to grow cartilage and it's not going to fix your knee. So again, with the hip replacement, there's no prohibition about activities. I generally tell people avoid things where you could have an uncontrolled fall. That's more of a safety issue. And having a fall or some trauma leading to either a paraprosthetic fracture or fracture around your implant or a dislocation can be catastrophic. So, remember, theoretically, you're older, you've had a surgery, doing silly things is silly. You can pretty much do any activity you like. Relative to range of motion, I would suspect your range of motion would be a bit improved, but we aren't changing the soft tissue and capsule and other structures around the hip. So they're often a bit contracted. They can stretch a bit. Generally, people, even if their motion isn't great, their motion is far less painful, so it doesn't feel like it's as restricted. Again, for all of these procedures, the goal is to make what you're doing now better, not to go back and to do things you weren't able to do before. But I suspect you'll be quite happy and go back to doing most anything you want. The happiest people tend to be hockey players because they go back to skate without pain and are pretty happy doing that. Well, I hope you don't have a limp. People limp for a couple of reasons. One, they limp because of pain. Sometimes they limp because they can't fully get their knee straight. And I would hope those 2 things would be resolved from your operation. Knees are hard. So the first 6 weeks are a struggle, the first 2 weeks particularly. After that, at 6 weeks, you're probably going to be about 75, 80%. 75%, getting the last 25% over the next 6 weeks. So at 3 months, you should be pretty much where you want to be. That being said, a common complaint at that point is endurance and stamina. Don't forget, you've had many years to get weak, to lose agility and balance, and that will not come back without long-term training. So there's really very few things that would dictate what approach you would use to do the hip. None of these approaches are new. They've all been around for over 50 years, and the data on which one is better hasn't really borne out well. There are definitely advantages and disadvantages to all of the different procedures. The potential advantages of coming through the front, which is really not quite front, but yes, is maybe in the first couple weeks, you might have a little bit quicker first couple weeks. Maybe the dislocation rate is different, but that's a little unclear. But you definitely have a much higher risk of fracture, a much higher risk of bleeding, and a much higher risk of having a nerve palsy at the front of your hip. So, and it's not as extensile. So if there was a problem intraoperatively, exposing the hip to fix something is harder. That being said, I think rather than choosing how you want your surgeon to do the case, you're better off deciding who you want to operate on you, where you want the surgery to be done, confirm through data that it's a high volume center, a high volume surgeon with defined and good outcomes. And the statewide registry is tracking that well. And secondly, make sure, because problems do happen, that whoever you're working with, you're confident and trust them, so that if you do run into a problem, you're going to allow them to get it taken care of. Because what you don't want is to look back and woulda, shoulda, coulda. And if you're ready for a hip, you'll do great. Don't worry. So I generally tell people not to have dental work for 3 months. And that's just because you probably get bacteremic or have bacteria from the mouth in your blood. And I don't like that when the wounds are healing. Thereafter, there's some debate. Certainly within the first couple of years, antibiotics are warranted if you're having dental work because you do stir up bacteria in the mouth. Personally, I believe, or let's say, if I had a joint replacement, I would take antibiotics whenever I had dental work, forever. It's easy, it's cheap, it's very innocuous. If you're bone on bone, that I'm presuming someone took an x-ray and can show you that there's no space in your knee. It is true that people can often have advanced arthritic changes by exam and x-ray, but don't feel like they're having a problem. And that's okay. If you can do the things you like to do, if you are not giving up activities, if you're not putting yourself at risk because of instability, that can be followed. What you want to avoid is having bone loss or run into a problem that could be more challenging to fix. But your surgeon or other provider can follow that and keep track of it. I think the one thing I would think about is it's very common for people to say, I don't have any problems, but part of that is because they've been adapting their problem to accommodate their life. So as an example, I had a good friend. We used to play cards. He was quite a bit older, and Bud, we'll leave him as Bud, had terrible knees. He used to drive me crazy. And I'd say, Bud, why don't you get your knees fixed? Oh, I got no problem. I play golf every day. I'm like, yeah, you used to play tennis. You then started playing doubles tennis. You then started playing mixed doubles tennis. You then gave up tennis and took up golf. You then walked the course, 18 holes, then 9 holes. Now you ride the course. Now you ride the course with a handicap card. You park at the green and you putt and you go drink with the guys after. So over time, he's gone, slowly down, step by step by step. But as far as he's concerned, if you ask him now, he plays golf every day. And so I think it's important with these cases to sort of track what you're doing, what you're giving up, talk to the people around you. It's very common when COVID has been a problem because we can't let people back. And, it used to be that I would have, we'll pick on the men, the husband on the table and the wife in the chair. And the husband's like, oh, I do everything. I cut the grass. I do everything I want. I don't have a problem. And the wife would look at him and go, you don't do anything. You're getting your knee fixed. I can't take it anymore. You won't go anywhere. You don't go shopping. You sit in the food court. So, part of it is sort of figuring out what you got. If you want to do that, tracked planning is good. take your phone, take your computer, whatever, take a piece of paper, write down what you did that in the morning, write down what you did in the afternoon, and you can see your activities over time. And I suspect if you have a really bad knee, you're going to see you're not doing very much and you're backing off on the things that you might want to do. You have a hip replacement because you need a hip replacement. Now, that being said, there are certain comorbidities that we clearly can define as being problematic for joint arthroplasty replacement. If you're diabetic and your A1C is over 8, maybe 7.5, then that needs to be managed, or that is a identified comorbidity to put you at risk for complications. So for example, if you came to the office and you had diabetes and your A1C was 9 or 10, I'd tell you, we're not doing the surgery. Go back to your primary care doctor or your endocrinologist. Let's see if it's under control. Let's see in 3 months. And if we brought it down, then we would do it because we knew we could do it safely. So it's what we call a modifiable risk factor. The hope would be that the knee replacement would last you forever. If it lasts you past the first 5 years, which is the highest failure rate, good chance it's going to last 20 years or more. Hospital or operative stay, hospital stay is entirely based on your condition. I anticipate that next year, 50% of my knees will be done at an outpatient center where there's no hospital. So the vast majority of total knees and hips are done with either no hospital stay or just an overnight stay. But to do that takes a lot of prep. You need good support. You need a good environment in your house. You need to get all of that set, because we know that rapid discharge from the hospital keeps you out of the sort of high risk areas, and definitely going to nursing homes, which you call rehab, but it's a nursing home, has a extraordinarily high complication rate. There's a little bit of a debate on the best path. There are many who think you don't need any therapy for a hip replacement. Now, I think therapy is great. I've had therapy myself. I think the therapists are very attentive. They can help with pain and function. They help teach you things you didn't really know. Our pathway right now is go home. We often will have a therapist come see you once or twice at home and make sure things are safe, and then start outpatient therapy at 2 weeks. There are many services that will start outpatient therapy immediately, but basically we want you up and moving and going quick.